because a couple months ago I said to Jim, I said, our families are so anxious, I can't even tell you. And he volunteered to come down, and then we got lucky and we got 2 for the price of 1. So we have a little something because you were good newbies to come. But I will ask too, because we're a fairly vocal, aggressive group, that we not be aggressive and that we be vocal, but in a way that doesn't make this worse than it is, because we all are here to learn tonight. No, please, I'm begging you. That doesn't serve a purpose. We need everyone to listen to us, and we need them to hear our voices. So what you will see is the questions that you submitted up on the screen, and we're going to get a lot of information tonight. The commissioners allowed us to take this, so we're going to put it up on our website until she tells us to take it down because things are changing. But we're really so grateful.
Excellent, thank you very much. And I want to thank everybody for coming here tonight. I know that it can be a big strain sometimes. I know that a lot of you had to leave your families, had to leave your kids to be here, so I really appreciate your time. And I know that some of you traveled a long way because we talked to somebody who had come in on the subway when we were walking over here, so thanks. I just want to give a brief overview. I know that a lot of people here already know what the waiver is about. You've been following the information that we've been making available on our website, but some people haven't, so I think it's helpful for me to just go over a few of the basics, talk about where we are in the process, and then we can open it up for question and answers, because I think that's what most people are here for tonight. So why an 1115 waiver? Well, a waiver is an opportunity for the state to look at the way we're delivering services and think about how we can do that better. So there were, of course, a wonderful system of services in New York State, thanks to many of the people in the room here who have been tremendous advocates in building that system over the past several decades. We want to make sure that we build on what is great about the current service system, but we also know that there are some improvements that could be made. And there are a lot of different pressures that are, for better or worse, are making us make the system better. And there's 3 particular things that we're looking to improve with the system, with this waiver process. The first is that we know our system has been what we call very supply side oriented. So we have a lot of services, but there's not a lot of flexibility for individuals and families to choose the services that they want. So the first thing that we want is more flexibility in the system. We want to build on some of the successful programs that we've had that are more flexible, like consolidated supports and services, like the ISS program that allows people to live in more integrated settings if they want to choose to do that. So that's the first thing that we're trying to do with the waiver. The second thing is that we know that managed care is happening in New York. There's a whole separate process going on outside of OPWDD through our state's Department of Health. It's called the Medicaid Redesign Team. They are looking at how do we change the whole system into managed care. We know that we have to do that as well, but we want to do it our way. We want to build on the system we have. We want to build on the provider base that we have. So the 1115 in many ways provides us a buffer from what's happening in terms of overall healthcare reform and moving to a managed care system. And it allows us to do it our way, and it allows us to build on the great network of providers that we currently have. What we envision for managed care, and we've talked about this, is a developmental disabilities individual supports and care coordination organization, a DISCO. It's a catchy name, it's easy to remember. Well, what does it really mean? Because we haven't seen one yet. Well, that's part of what this process is all about, is how do we get from here to there? If we're going to be the ones who are creating what these managed care organizations look like, and we want to build that from our current provider base, then we've got to be different than the regular managed care organizations. We've got to be our own thing, and that's why we felt it was important to come up with our own name for what these would be about. We also felt that within that managed care model, one of the things that we want to demonstrate to the federal government and why we have to get this waiver is we want to prove to them that our model of person-centered care is something that we can do within a managed care framework. A lot of our providers are doing it now, so how do we make that work in a managed care environment? So that's the second thing. So the first thing was more flexibility in how services are delivered. Second thing is managed care, OPWDD style. The third thing that we requested in our original concept paper to the federal government was changing the funding system to be more transparent than it is right now. As families, as advocates, you don't know what all that money is being spent on. There's a lot of money coming into our system, but it's hard to say where it's going and what it's being used for. So we want more transparency, not just in areas that we're having more transparency in right now. For instance, we've been providing information about how successful providers are in our system, and we've been putting that information on our website. We've been letting parents know if we have providers who are doing exceptionally well, such as our Compass providers, or providers where we're having trouble that we've put on an early alert list. So building on that idea of parents and individuals should be the ones who are empowered with the information and have the transparency, we also want more transparency in our financing system. And that financing system also has to support our first two goals of being more flexible for individuals and families, offering more options such as consumer-directed services or individual-directed services, and it also has to support the idea of managed care. So we've done a lot of planning this past year. We've involved families, we've involved providers. I know there's people in the room here who are on some of our design teams looking at, okay, if we're going to get from here to there, how do we design this system? So we asked parents, families for input, not only through our design team process, but through a request for information process that just finished up at the end of last month, where we said, help us in figuring out how we can make sure a managed care system can work within the developmental disability community. So there's a lot of anxiety out there, I know, because I've been hearing about it from when I first started listening to her last spring, to hear from families and individuals about what do you like about the current service system that we should be sure we preserve, but what do you want to see differently? And people have said, well, are the services still going to be there? Yes, that's one of the major reasons we're doing this, is we're committed to sustaining the funding level that we currently have with the federal government. But we know that that funding level hasn't been transparent, and so we've got to work with them into redesigning the new financing system and what that will look like. But I think the anxiety on the part of families and individuals has been that we don't have all of the answers about how these managed care organizations are going to function within our system, because we want it to come out of the providers who are already out there. We want it to come out from our own families and individuals. How do we make this work? And sometimes not having all the answers makes people uncomfortable. But the reason we don't have all the answers is because we want to do it with you. We want to do it from our own provider base. So we've been encouraging providers to start to think about, if our goal is to provide more care coordination for individuals, to make sure that they have access to a full range of services, what does that mean for you as a provider? If you're providing care management services right now, you're going to want to continue to do that in a care management environment, but you're probably going to have to talk to a larger set of providers than you're talking to now if an individual is going to have access to a full range of services. So our system has been a lot of long-term care, but it hasn't necessarily done well at talking to the mental health system, for instance, or the hospital system. If we want to make sure an individual can get all those services, all those providers have to be talking to each other. That's the concept of having providers come together and function as a disco. So those are some of the basics in the overview. You know, this is a process. Things are not changing overnight. Another reason we chose this type of waiver is it allows us to demonstrate how effective we are at ensuring that person-centered supports are delivered through this type of model. So what would happen over the next couple years is we would have some of these demonstrations initially, but we have to get permission to do that first, and we're not there yet. We think we'll get permission to move forward sometime this year. At that point, we will then develop what's called a request for applications. And the request for applications asks providers to come together and to demonstrate that they can deliver better outcomes for individuals and that they can deliver it in a care management environment. Then we evaluate how well those different models work, and for whatever is successful, that's what we try to take statewide. So all of this happens over the course of several years. Once we get the word that we can move forward, it's about a 5-year process between when we hear the word yes, begin, and between when things are really full-scale statewide. I know some people are from different regions, so it will not look the same in every region. Some areas may not have the capacity of providers to provide the full range of services, so they may have to be what we call a partially capitated model, which means you're only providing capitated services for maybe long-term care. But other regions should have the ability and the provider networks to be able to provide a full range. So a lot of, it's a very exciting time. It's our commitment to try and make sure that our system is sustainable for the future going forward, and it's also trying to make sure we survive and maintain the best parts of what's been built over the past several decades, given all the changes that are happening nationally with healthcare reform, given all the changes that are happening at the state level with managed care. Jim, I don't know if you want to add anything before we get into question and answer.
Yeah, I just thought I need your password. I don't want to look at it, but one of the questions that we got, which I thought was a great question, and I won't attribute it to Margaret, but was, what is the cost of the system? Where do we spend, where do the resources go? And that's a great question. I don't know who, if you're in the room, raise your hand if you asked that question. It came from Buffalo, okay. I mean, this is something that we really have not spent a lot of time working with people. Families don't know what is the state spending the resources on. What are the services that we do? And I think, and then we'll get into the more detailed questions that you all have. But I think just to give you a little bit of a sense of this, when you look at total spending involving people with developmental disabilities, it's about $7.5 billion, right? That includes money that's in our OPWDD's budget. It includes resources that are in the Department of Health's budget. It includes resources that are in OMH's budget. Of the roughly $7.5 billion, about $6.5 is OPWDD spending, right? Of that, 91% of the money is spent on group homes, or people attending certified day programs. 91% of the resources are going to those two areas. We support over 100,000 people. 30-some-odd thousand live residentially. And of that, probably about 20-some are in what we would say 24/7 settings. So the bulk of the resources are going to a small percentage of people that we support. So that leaves about roughly whatever that is, about 9% to support everything else, including service coordination, which is about $400 to $500 million in our system. So just to give you a little bit of a sense of where the resources, how, and this really has sort of, you know, it's ramped up over the years. And I think, as the Commissioner said, this is not a sustainable future for our system. We have a lot of people in need. That's why you're all here. You know, we always have people, you know, looking for help. And group homes and the cost of group homes are not the answer. We have to come up with other solutions and how best is to provide individualized supports and services to people going forward. Because we have to take care of everybody, right? And the resources are not limitless, whether it be at the state level or the federal government level. Last year, the state had a $10 billion problem, financial problem. This year, it's $3.5 billion, right? And we're fortunate. Our budget got cut very little this year. Yet we got more people we got to help. So how do we do all of that with $7.5 billion? That's a lot of money, right? How do we spend that money better, more effectively, to provide the supports and services that people need? That's what we have to figure out together. We don't have the answers yet. I know that's hard to believe, but we do not have a master plan that people think we have. This is about working with families, working with providers, working with the advocates on how to create what we would say is a sustainable future in support of people with developmental disabilities. So I just wanted to sort of give you a thumbnail on the numbers just to kick things off.
Okay, so how do we intend to make sure that children, adults with high needs will be taken care of under the People First waiver? We've gotten this question before, and one of the ways that we're looking at doing the financing under a capitated system takes into account what in the medical world is called the acuity needs of an individual. so that we make sure that there's no disincentive for a provider to take somebody who has high need. And in fact, they'll get a higher reimbursement so that there's not what's called adverse selection of discos picking, cherry picking, as they say. I guess similar to that, what type of enforcement provisions in the waiver would be applied to discos so that they accept and continue to accept high needs children and adults? There's really two enforcement mechanisms. One is the contract that we sign with them, and we can put certain stipulations in that contract about the mix of individuals that they might be serving. And second is making sure that we pay appropriately so that there's not some financial disincentive for them not to take certain individuals.
And just to be clear, we already struggle with this without the waiver, right?
Yeah.
This is
They
a
all wind
problem.
up here.
Pardon?
They wind up here.
Yes, it's interesting. A lot of people, in asking questions about the waiver, are asking questions that are concerns about our current service system.
Right, exactly.
And the waiver will solve some of those issues, but it won't solve every problem that currently exists. Okay.
Keep skipping question two.
All right.
Oh, you're going to skip question? Oh, I'm sorry.
How does the state propose to meet its deadline given the glaring operational gaps that still must be defined, designed, tested, and rolled out? I can tell you that we've set the goal of April 1st because in one sense it's easier for us given the state's budget cycle, but we also know that we have to be careful in not moving too fast. The federal government is not going to let us move too fast because this is a negotiation with them. They pay for at least half of all the Medicaid costs. So right now we're in I would call a high-speed negotiation with them, going back and forth on the phone about a lot of the same detailed questions that people are asking. We've had 3 calls. I think we've got 2 more, and then we've got an in-person meeting. And what we've asked is that a lot of those things that we've been talking about with them conceptually, that they ask us those questions in writing, and that we put our responses in writing so that we can make it available to everybody publicly so that everybody's on the same page, everybody knows what the conversations include, and that it's clear about what's going to be in the waiver. And that would be the beginning of what they call the terms and conditions of the waiver. It's basically the agreement that we have with the federal government about what the system is going to look like. So we're working on a lot of those as we speak. We had a call today. We've got one tomorrow with CMS.
But I think the other important point is that, as the Commissioner said earlier, the world is not changing tomorrow. As of April 1st, things don't automatically, the world doesn't change April 1st, right? We're talking about doing pilots, right? Pilot programs. So, again, services aren't changing the first day of the waiver goes into effect. It's going to be a gradual change over time. We're going to be assessing based upon the pilots that we put into place around the state.
You add a
We're
layer.
also trying to pick out ones because some of the families couldn't make it, that the families who aren't here tonight because they couldn't, it was a visitor's day. So we want to make sure we capture that because once we have access to the commissioner, our population is often so limited. So attending your meeting.
Can you speak to a microphone, please?
Oh, I'm sorry.
Okay, so this says, how can you add a layer of bureaucracy to the process of matching the disabled to their needs without financially shortchanging the available resources that they are trying to connect to or cutting back on the number of persons who can connect to those resources? One of the hopes in having DISCOs is that we will see some administrative savings. We've already been encouraging providers to think differently about how they interact with one another and to think about how they can already create efficiencies in terms of coming together and sharing a lot of those administrative and back office services. We're doing it ourselves as a state agency. A lot of that, we did it, the draft budget was released yesterday by the governor. So we're asking the nonprofit providers to do the same, to think about how do they start to align themselves in a way that's more efficient, that serves the individuals more holistically. So I don't see it as another layer at all. I see it, in fact, as a potential area of savings. Right now we've got over 700 providers, which is great, because it's a lot of providers, but that's also a lot of administrative overhead. That's 700 human resources people, that's 700 executive directors, that's 700 training offices. So how do we make sure we get some of those efficiencies in the system? And that's a goal of encouraging providers to work together, not just to serve individuals holistically, but also to achieve some of those savings.
Can you define what you mean by provider? Can you list some examples? Is SNP a provider?
Yes. Somebody asked, could we define provider? So yes, SCIP is a provider, somebody who provides Medicaid service coordination, somebody who provides day habilitation, somebody who provides residential services. It's that whole array that you're probably thinking of. I'm not counting nursing agencies in the current count of 700 providers, but they could be, a nursing service provider could be part of an alignment of providers that could be designated as a DISCO. My service coordinator informed me of a cap amount that each consumer can spend every year under the new system. How will this amount be decided for each individual? One of the things that we're looking to do under this waiver process is to develop a new assessment tool, or to build on an assessment tool that's already out there in the field. And the design teams this summer spent a lot of time looking at assessment tools that are out there that would be better at matching individuals' needs with the services that are available. So the first part of this would be better assessments of what an individual's needs actually are. A cap amount probably refers to the idea of capitation, where a provider gets a set amount that's based on actuarial sound analyses of the people that they may be serving. And so that gives them a set amount to then try and manage the services that the individual is receiving. I think right now we actually, based on historical rates, which a lot of this will be built on initially, we've had a lot of oversupply in many areas. So we think that's a good thing for us, is that the initial amounts for the caps will be good and we'll be able to cover the services.
And the state would continue the responsibility of doing those activities. I'm sorry. The state would continue to do those activities in terms of the assessment and then the determination of the funding. We want those two things to be separate, right? Because you first want to do an honest assessment of individuals' needs, right? And then from that, come up with what's the reasonable funding that would support that person's needs, is what the thinking is.
I'm sorry. Melinda's saying what we're trying to do is get to the broadest question. So we have the deepest understanding and then open it up to questions so we can drill it down. Because I know that many of you are hearing the answers, and it's hard to understand our population. So you're saying, well, where is my independent private duty nurse going? I know that's a question. I know that that will come back. But let's try and burn through this and get an understanding of what their design is, what their thoughts are. I want to know what the feds have said no to. I want to know what the feds have said, oh, terrific to. Those are all our questions, because this is the plan that you will be shaping, that all of us will be living with. So let's get to as many as we can and then, you know, narrow it down. Is that good?
How will the waiver affect the service coordination we currently receive? Well, service coordination is a major part of what we want to see in the new waiver. I would say it would be service coordination on steroids, really, with a larger team of people being involved in the service coordination than might be the case in some certain regions right now. It would be part of making sure the care coordination, that would be part of what a DISCO would have to do. So depending on the alignment of providers within that DISCO, they're probably going to contract with a lot of MSC type agencies to help with that care coordination, I would imagine. But again, since we're trying to get this to be driven by the existing system, it's not going to look the same in every region, because the available providers that are there is going to be different depending on where you are in the state. And how those providers decide to work with each other is going to be different in different parts of the state.
I think the other Medicaid service coordination. One of the other key things with this is the notion of transparency and separation, right? Because that's one of the other things that the feds have asked us lots of questions about, ensuring separation, right? And clearly service coordination from being the provider of that service, people raise questions about that, including the federal government. So going forward, one of the things that we have to plan into this is how those things are going to be able to have some kind of a firewall, right? And we also, the waiver is also going to require advocacy services, right? So that's another piece to the waiver that will be there that, quite honestly, we have to a degree now, but it's not what I think the feds are going to expect us to have under the 1115 waiver. So I think that's a good thing. And again, it'll force transparency, and it'll also, where it's not a one-stop shop as it relates to only this provider provides everything, right? Which is a lot of our world today, you know. So that's an important point to be had.
I'm curious to understand the impact this will have on nursing providers we're currently using. Also, we have traditionally had some input into nurse selection, and we're curious to know if that would change. I'm not sure if I can answer the second part of this, but the impact it'll have on nursing providers. Well, nursing providers are obviously a provider that's going to be needed in the new system.
Long-term care?
There is right now a horrific nursing shortage. For the bulk of our families that get private duty nursing, they have what's called independent contractors. So I guess the question is would the independent contractors who they can hire, they can select, they can do all those things with, have to be part of a disco? Is that your question?
The second was, if the disco that we were assigned or selected didn't necessarily have a relationship with the agency that we're using, would we have to change, the nurses?
I love anxious skip parents. Thank you. Did you get that question? Yes.
Well, each disco would have to have a range of services and benefits that would have to be provided. So he was asking a question as to whether nursing providers would be part of the disco, and if they weren't, would somebody have to go to another disco? There's a set list of services that would have to be provided by every disco. So they would, regardless, the disco would have to contract to make sure that those services were available to meet the individual's needs.
Sure, but what about if we have relationships over many years with a particular agency and a particular set of providers that we're being forced to change with even a very deleterious to our ability to care?
So you're worried about the relationship that you currently have and what's that going to look like? My recommendation would be to continue the conversations with who you currently have those relationships with, and to say, how do we continue to work together in the new world?
You have to understand, though, that in a model where the discos are going to respond to lowest bidders, it's often not going to be the case. The agencies that we need to use, or the independent providers that we're going to use, are going to be able to be the lowest bidder. Correct?
I'm concerned about lowest bidder. The way that we're trying to counteract that and how we're structuring the financing under the waiver is to start to pay more for what are the outcomes for the individual, rather than who do they contract with and who's the lowest cost. Looking at what the outcomes are for the individual, if you're providing better services, that's one of the things that's going to be looked at in terms of how the financing is done.
I think the other thing is that you're going to have input into your plan. I mean, there's going to be a plan developed for every person, right, under the waiver. And there's going to be expectations that advocates and families are at that table having those discussions, right? And as you just said, there's a nursing shortage. There's only so many places you can go anyways, right? So it's going to be in everybody's best interest to try to maintain those relationships where they exist, because who wants to burn that bridge, if you think about it, particularly around nursing? You know, this is not we're not talking about, a service you can get from anywhere, right? We know that there's a shortage. So clearly that's an issue that has to be dealt with. In terms of the other part of the question, which has to do with selection, one of the things that the commissioner has been adamant about, and actually the feds have been asking, is actually today they posed the question about where does self-determination, right, and input, choice on the part of families come into this, right? And clearly the expectation is that has to be there. We have to. So a disco will have to provide, again, this will all have to be spelled out in the agreements that we have, but the expectation is that to the extent that people want to self-direct services, right, that option has to be there for families. We have to make that happen. So that is a commitment that the commissioner has made, and CMS is going to expect that of us, right? It's not going to be the status quo. I think the concern that people have is that we're talking, I'm sorry? Oh, I'm sorry. Centers for Medicare and Medicaid, that's the federal entity that sort of holds the money with respect to the federal dollars. That's who we work with, as well as the Department of Health. You know, that's where Medicaid funds flow through. So those are the ones we're negotiating with and having these discussions. But the kinds of questions, as the Commissioner said, the kinds of questions you're posing are the same questions CMS is posing back to us. Because they are looking at this, well, yes, it's a financial, this whole thing ties to financial issues, but the bottom line is, what are we going to do that make the lives of people and families better? And that's the push that they have on us. And we do know we need to make changes. Because the kinds of things that people are worried about are problems in the current system today that we have not been able to solve, and people think we have the greatest thing going, right? So there's always room for improvement and change.